Okay, can I start?
I think you can start. Let me see here.
Yeah.
All right, go ahead, Ahmed.
Yeah. Question 23. An 85 years old woman present with dry gangrene at distal portion of her right great toe. Non-invasive testing reveals an ankle brachial index of 0.4 on the right. An angiogram revealed no evidence of inflow disease, but moderate occlusive disease of the right common femoral and origin of profunda femoris artery. There is a flush occlusion of the superficial femoral artery with reconstitution of tibio-peroneal trunk and inline flow of the posterior tibial artery into the foot. So the IPSI lateral great saphenous vein has been previously harvested for coronary revascularization. The conduit associated with the best long-term patency is.
Okay, before we go to that, what the problem here?
Yeah, so this is a patient came with a critical limb ischemia and gangrene already with low ABI. She had multi-level infrainguinal disease, and she needed a surgery to repair that.
Why not in the vascular? Why not in the vascular?
So she had common femoral disease, and the profunda needs it to be treated, and she had flush occlusion at the superficial femoral artery, I think. So this is all against endovascular.
Yes, but the most important that she has SFA and popliteal both occluded, you know?
Yeah.
Usually they don't work. I mean, you can see people do you open them, but really they don't work for a long time, especially have only single run off. So when I see SFA and popliteal both occluded, I think, I mean, you can try it, you can open them. I see many times they open, but will not stay open. I mean, they're occluded. And you cannot stent the popliteal and SFA, everything, be too much stenting, you know. So really, usually they don't work, you know. So when I see like that, I don't even try intervention. I think they should go right away to surgery. Unless if you have extreme reasons, she's high risk for surgery and all the things, then you may try it. But long-term medicine will not be great, you know. So now really my indication to go right away to surgery if I see SFA and popliteal both occluded, flush SFA occlusion, popliteal occlusion, I think I'll go just bypass right away.
Yeah.
So everyone needs a bypass. So the problem now is that your vein from this leg is being harvested. So let's see what options they give you here. See what option you have. Here are the 4 options. So which one you have to take now? You need a conduit. What is the best conduit?
So contralateral great saphenous vein.
Okay.
For me, this is below knee, so the great saphenous vein will be my first option.
Okay.
So spliced small saphenous vein.
Okay.
I don't think it will be long enough.
Mm-hmm.
Spliced arm vein.
Mm-hmm.
Again, this is the next choice for the contralateral. Heparin bonded BTFE. If it's above knee, I will choose this, but if it's below knee, no. And poly BTFE with distal vein batch. Still not the same as great saphenous patency.
So which one you pick up?
First one.
The contralateral greater saphenous vein. I think I agree with that. Well, let's make it more difficult. Let's say the other saphenous vein is not available. Okay.
Yeah.
So which one are you going to choose?
So I think I will choose the arm. Still below knee. Yeah.
Yes. Use hand arm. Yeah. This is what the book here, but practically, I mean, we have one of these.
Yeah.
Let's see who's with us. I usually, if I me, how old is? Let me see how old the patient. She is 85. So also you don't want to put a lot, you know. and she mainly has gangrene of the right big toe. So you don't need to also belong to. So 6 months pregnancy will be good for me, you know. So I was saying, because first, I don't know if you ever use the arm vein. The problem is the arm vein very thin. Most of them, they are already damaged because especially 85, she's been punctured with the arm many times, you know.
Yes.
Then you have to put 2-3 veins together. So it's not the best surgery. Yes, I mean, as patency and book, they said the vein will go next. But practically from the standpoint, most probably I will go with the PTFE with the distal vein patch and put patient on warfarin. This will be my next choice, you know. But if you come in the exam, mostly they wanted to say an arm vein. Ali, what do you think, Ali? Ali, we have a senior here, Ali. Ali Nahas, I don't know if you can hear me.
Yeah, I hear you. Good evening to everyone. I think that this question is a tricky question because I think she is 88 years old, no?
Mm-hmm.
Yeah.
85. Sorry,
80 old.
Yeah, something, 85. Yeah.
85 years old. The other lower limb, I think here is normal, no?
Yes, I mean, you can say normal. She has muscle vascular disease, but also because you have it one leg.
For this reason, I'm saying that it's a tricky question. 85 years old with the other limb normal or almost normal, and she has this occlusion, long occlusion. I think in these patients, the hyperviscosity because of lower input of hydration. I think it is the cause of the ischemia in this case. The question doesn't signal any time of appearance of this lesion or of this ischemia. Is it from 2 days, 3 days, 1 week, or it's more?
Ali, any question here? I understand your point. I 100% agree with you. It depends how long the occlusion. But the question they want to ask you here, they already made a decision. For some reason, we already made a decision. You want to do a bypass. You see,
yeah,
that was
they want to do a bypass.
So which kind are you going to use? This is what they.
I am with E. With the
small
I like this polytetrafluoroethylene with vein patch. I will not go to the other lower limb to harvest the vein. I will leave it for the other limb if she will need it in the future. I will go for polytetrafluoroethylene with distal vein patch, really, in this case.
I mean, yes, I mean, this is other options. But now, I mean, this was my teaching long time ago, same like just leave the vein for the other legs. But now I think what they want to get the problem now and leave the other leg for later on. We don't know. She may die even before she get problem in other legs.
Yeah,
so worry?
Yeah.
So
I'm saying this, Samer. Yeah, I'm saying this, Samer, because yesterday I did an 88 years old female. She came to me 10 days ago or 1 week ago with severe ischemia, bilateral severe ischemia. Multi-slice had lesions like this. So I prepared for 2 bypasses, bilateral bypasses of this patient. They went to another places, then they returned the day after.
Hello?
When I open, do you hear me?
Your voice come and goes.
Do you hear me?
Yeah, now I hear you. Go ahead.
When I did the operation Yeri, I did only Fogarty of both lower limbs, and I restored a pulsed popliteal artery in both legs. She has many problems in the tibial arteries, but I didn't make any bypass or any artificial or bypass. I'm saying this to ensure one point for our fellows, that these patients at this age, they may have dehydration as a problem or as the trigger point of this thrombosis. So to put it in mind, and to leave it in mind in this case, in these patients, in these old patients or geriatric age, as you say. For this reason, because yesterday I did one bilateral lower limbs with almost the same problem.
Okay, thank you, Ali. This is, guys, show you how the book is different from real life, because really, real life is every patient. You have to look at every patient in specific and how is his condition, you know. And sometimes you may do like the E because it's faster. Maybe patient has high risk for surgery, has heart problem. You want to do something quick and fast, so you go maybe with the E, you know, or Dr. Ali said something different, you know. But
if you find fresh thrombus in the when you open the artery, I think keep Fogarty in mind.
Yes, that's true. This is true. So this is what you can see, that it's different. Most of you make a decision during the surgery or depending how is the patient condition, but the exam is different. Exam, you have to be safe. You have to go with the book. You see, yeah. I just show you how the life is different from the exam. When the exam, you have to go with the book. So if I come this in exam for you guys, for the fellows, then I go with A. If it's not, I go to the arm vein. If it's not available, then I go with a heparin with a distal vein patch. This is the way it should be, you know. So try to do that. But in real life, it's different. I see Dr. Ali, he has different scenario, I have a different scenario. You may even try endovascular. But in the exam, guys, be systematic and be as conservative as possible. And try to do what the book said, okay?
Sure.
Right. This is good. Great. Thank you, Ali. So let's go to the next question. Who's going to take it? Ahmed, Muntin. كيفك يا Ahmed? Let's take this question, Ahmed.
Arthrectomy before doing the femur.
Sorry, what's that?
Do we need to do common femoral artery endarterectomy before doing the
they said it's moderate, so I don't understand how you mean moderate. It depends how it looks, Muhammad. But yes, if you have a disease, you need to fix it. Yes.
Okay, so fix it before going to.
Yes.
Okay, sure.
Yeah. Thanks. Okay, Ahmed.
Okay, 68-year-old woman. She presents to the emergency department with a dry gangrene of the right great toe. She has a white cell count of 22,000 and ascending erythema in the foot. She has a palpable femoral pulse with only weak monophasic signals in dorsalis pedis and posterior tibial arteries. The angiogram shows an occlusion of the SFA and reconstitution of the above knee popliteal artery with normal runoff. Both antegrade and retrograde revascularization were attempted without success. The most appropriate next step of management is?
Okay, so this is patient, she's 68, and she came with a dry gangrene, but the problem, she has WBC 22,000. So she has a bad infection, okay?
Yeah.
As only occlusion, it's a good runoff, you know. Usually these people will try endovascular first. Yeah. That is why they said, even the guideline, they said you try endovascular first. You tried that. They did antegrade, then they didn't work.
They didn't
give you a choice. They said even they tried retrograde because they say, okay, I'll try retrograde. So they try even antegrade, retrograde. They were not able to cross the SFA. Okay. So what's the next step to do? Let's see what the option they gave. Let's go with that. Go ahead, Ahmed.
I don't see the options yet.
I don't see.
All right. So amputation with the primary closure and antibiotics. Reattempt endovascular recanalization after two amputation.
Ahmed, we want to discuss everyone. We're not taking an exam, just right. So what about this option? You think it's good or bad?
So amputation with a primary closure and antibiotics. The patient is clearly having an infection. He will need, he or she will need antibiotics, but without revascularization.
But this could be a good option. So it's correct to amputation.
Yeah, it's a correct one.
It's a correct one.
Is it? It is a correct. It's a good one.
It's a good option. What the problem was this answer? What's the problem? There's one problem.
The patient will not maybe will not heal after the amputation.
No, there is something worse. What they said, primary closure.
Yeah,
Right?
yeah. Oh, sorry. I did not read this one. Yeah, they will close.
We don't do primary closure with the infected, right?
No.
So this exclude this. This means wrong because we don't do primary closure. So this is take it out. So it's not correct. Let's next one.
Reattempt the endovascular recanalization after toe amputation.
I don't think it's a good option. They already tried twice.
They tried the recanalization
Let's
already twice.
Super or different. Some people they do
It
that.
doesn't make a difference.
But I think they already try anti-grade to grade. I don't think it's a good options. I mean, some people they may do that because they think maybe that other people they're not as skillful as they are, but it's not a good option. They want you what the best option, you know. So I don't think it's a good option. Let's go to the next one.
Then right femoral above knee popliteal artery bypass with 8 mm heparin bonded PTFE with the PTFE graft with the grade 2 amputation.
Okay.
Then there is synthetic graft in above knee.
Okay. We know that the patency for above knee bypass is the same for PTFE and vein. All the solutions the same. So what do you think is a good options? Well, let's say next one. Let's keep it to the side. Let's go next one.
In the right femoral above knee popliteal artery bypass with a great saphenous vein with a grade 2 amputation.
So the same things. Just one with the PTFE with the vein. Okay.
And one is saphenous.
Okay, let's leave it alone. Let's go to the last one.
No, right ankle articulation is not an option.
No. So it will be C and D. So which one we should choose, even though we know the patency are the same?
The same above knee.
Right. So which one use? PTFE or is the vein? What the problem with this patient? What her main issue? Why she came to us?
She came with cellulitis, which is an infection.
WBT 22,000, right? So you have bad infection, and she has erythemia, so she has a bacteremia.
So I will avoid a graft.
Right. So the reason why you want to avoid a graft. Then we're going to go with
the venous graft.
You see, if there was no infection, then most probably my answer would be C. Because why should they use a vein, quicker bypass, you know, vein with a Gore-Tex would be enough. But the reason why, because they put an infection, you have a wet infection, you have WBC, you have erythemia. So all tell you she has a bacteremia, so it's better not put a graft, you know. The reason why the best option would be D. Okay?
Yeah.
All right, this is good. What's next one? Ahlam, you want to take one?
Yes, sure, doctor.
Okay, thank you, Ahlam. So let's go to 25.
Okay.
Yeah.
A 43-year-old man who has a history of smoking present with severe bilateral lower limb claudication. On physical examination, he has no palpable femoral or distal pulses. His feet appear normal, but demonstrate sluggish capillary refill. The CT aortogram is shown in the figure. The most appropriate approach to surgical revascularization.
Okay, so this is what her symptom. Her symptom is severe claudication, okay?
Yes.
All right, and she has no femoral pulse. So this is a CT angiogram. Let's look at the CT angiogram. So what happened, it looks, she has bilateral, this is external is occluded, this is the internal. So she has occluded bilateral external iliac. See, one here is occluded, one is occluded.
Yes.
The aorta looks fine. I don't see any major problem. So bilateral external iliac artery occlusions.
Okay.
For some reason, they decided to do
common femoral are occluded.
Go ahead, Ali, please.
I see well, the common femorals are occluded.
Not really, right? It's a profunda. I think, Ali, it's not picture, it's not very clear, but could be profunda in this area.
On the left, I see only the bifurcation. On the right, I see a stump of the common femoral before the bifurcation, I think. And for this reason, he is ischemic, very ischemic.
But Ali, you see epigastric on the right, you see epigastric artery here. You see up?
Yeah.
This is so the common femoral is open. Should this common femoral here on the right? On the left, I don't know if this is epigastric here. I think the common is open. I think mainly it's only the external iliac is occluded.
No, on the right, I see the circumflex. On the left,
Right.
I don't see the circumflex artery, no?
Yeah, I'm not sure. It's in the best picture. But anyway, I mean, the whole idea is that they want to do a surgery anyway, I think. Let me see what they said.
Yeah.
So they decided to do a surgery. Even though for me, as I'm saying, guys, different from a book. For me, I would try and do vascular here. I mean, if it's unless the common is occluded, you see, I'm not very clear here. I agree with Ali. If the common is occluded, then even I may do hybrid. I may do like endotomy and retrograde. I will not do aorto bifem for this lesion. I think, how old the patient? Let me see. 43. He's young, so you can argue. He's a young patient, but also you can argue, let's do endovascular. If failed, always you can do aorto bifem. You're not like really burning any bridge, you know. So it depends how you look at that, you know. So what do you think, Ali? Would you try endovascular first, or you take him right away to surgery?
No,
I'm receiving the common femoral is open.
I would try the endovascular, and I want the fellow to keep in mind the fem bypass. If you can recanalize the right axis, iliac axis, and you can make a fem bypass for the left one, if you want. Another option, the extraperitoneal iliofemoral arteries, bilateral extraperitoneal iliofemoral bypass.
Yeah.
If you want.
Many options. But let's see what they want, what options they give us here. Let's start one by one, okay?
Sure. Aorto bifemoral bypass with end-to-end proximal anastomosis.
Let's keep it on the side. The next one.
Aorto bifemoral bypass with end-to-side proximal anastomosis.
Okay, let's keep it on the side. Let's go to the third one.
Aorto biiliac bypass with end-to-side proximal anastomosis. It should be aorto bifemoral because we have external occluded and internal patent.
So this is wrong.
It's either A or B.
Right, because, well, let's finish them. So C is wrong. What about D?
D also wrong, aorto biiliac.
What about E?
Aorto aortic, no, it's wrong.
No, because the region is external iliac.
Yes.
Really, they want us A or B. And
yes.
You see A and B the same. The only difference between both is end to end or end to side. Okay?
Yes, yes.
So what do you, yeah.
And the issue is the internal iliac is patent. We want to keep it that way.
Correct. The reason why you want to do end to side or end to end? End to side. Right, because if you do end to side, then the blood flow will continue to the internal. If you do end to end, there's no retrograde flow from below because iliac artery is occluded. Then you know, then you lose the internal iliac. So you need to end to side. You know, I think this is a questions we used to get when I was in fellow. They used to love this question to differentiate between end to end and when to do end to side and end to end. But nowadays, first, I will never do end to end anastomosis anyway for aorto-occlusive disease, because end to side is easier. You don't have any problem with mismatch. Where if you do it end to end, I'm talking is no aneurysm for atherosclerotic disease, and the artery is calcified disease. You do your suture, doesn't take very well. There's no reason for you to suffer. So I don't see any advantage to do end to end. The reason why all the time when we do for aorto-occlusive disease, we do end to side anastomosis. So this is just the rule, but don't even try to do end to end unless if any aneurysm is different. But if it's no aneurysm, stay with end to side anastomosis. Okay.
Okay.
So again, this patient, I mean, if you do aorto bifemoral, it's not wrong, especially a young patient. You give them best treatment. But some people, they may argue, they may do different procedure, as I said, the vascular, maybe fem, as Dr. Ali said, aorto bifemoral, aorto biiliac retroperitoneal. So there's many options, but between the options they give to you, I think the best one is end to side, But remember, there's many options to deal with that, Anything else to add, Ali?
No, I fully agree with you. I like the end to side anastomosis, but they say in books that in females, it's better to do end-to-end because the aorta is small and can match well with the graft in case of total occlusion of the aorta. But in this case, I think it's end-to-side the right decision.
Okay.
But I think the young age of the patient is somehow leave you uncertain for this decision, I think, because he's very young, and after 5-7 years, what we have to do for this patient if he will go occluded, I don't know.
I mean, some people, they look at that now, Ali, is that even if you don't want to buy FEM, it's not lifelong.
I will leave the aorta for the years after. I think I will leave the aorta and I will use the common iliac artery both sides if I want, or on one side and FEM because he is young, and I will leave the aorta for the year after.
Yeah, I mean, it's different options.
Anyway, these are options.
Right. All many options available, Yeah, but again, guys, especially for the fellows, guys, my advice, don't try end-to-end, because the moment you do end-to-end, you commit yourself. You already cut the aorta. You have to fix it. If you have any problem with anastomosis, you get the bleeding, you stop, The reason why the aneurysm is very dangerous, because the moment you cut the neck and your neck is bad, then you are in a big, big trouble, Whereas the end-to-side, I mean, what the worst thing, the graft can thrombose, you may not, get nice stitches, but end-to-end, the moment you cut the aorta, you commit yourself. And this is the aorta nice and healthy, but imagine after you cut it, you find it is full of atheroma, you take the atheroma, then the artery becomes very thin like a paper, then you're stuck, And if you decide to do end-to-end, at least cut it away from renal. So you leave your space for, if it doesn't look good, you go a bit higher, But my advice, why need this all headache? Just do end-to-side and that's it. That's be my advice, All right. Well, let's go to next one. Next one, we go what? Muhammad? Okay, Muhammad, I think we are back to you, right?
Yes, Doctor, I'm ready.
Okay, let's go 26. Oh, too fast.
We did the same case 2 weeks ago, you remember?
Yeah, there is one.
Exactly
the same one, right? I did
even the age of the patient is the same.
Okay. Yeah. So yeah, I need the word to by 80. Yeah. All right. Bifemoral, sorry.
Bifemoral. Yeah. 26, a 78-year-old woman presents with left foot wrist pain and an ankle brachial index of 0.5. An angiogram revealed a high-grade left external iliac stenosis, moderate common femoral artery disease, and diffuse moderate to high-grade stenosis of the superficial femoral artery, with reconstitution of the below knee popliteal segment and 2 vessel runoff via posterior tibial and peroneal artery. Profunda popliteal collateral index is 0.1, and her symptoms can be adequately treated with. So, in summary, this patient presented with wrist pain, no gangrene, with angiogram as 0.5, mainly high external iliac stenosis and high SFA stenosis with moderate common femoral.
Okay. So, what is that? We called it, what is this? What's called it? Let me see here. Profile index.
Yeah, I didn't recall it. I read it once, but I didn't recall the number. Is it high or low?
Yeah, this is where you measure the collaterals, because always the question comes to the mind. Like we have a patient now on the floor, same thing. Like if you have multiple level disease, you have an inflow and you have an outflow. Like here you have an inflow iliac and common femoral, and you have an SFA occlusion. Okay, how's the popliteal? Let me see if it's stenosis. We don't. Yeah, or above knee popliteal occluded. So should we do like inflow and fix an outflow, or just inflow? Usually, the way I look at that, if patient only wrist pain, for me, inflow is enough. You just fix the inflow. If patient has an ulceration or tissue loss, then I fix the inflow and outflow. This is how I look at that. If you want to be more scientific, then you go what we call the profundopopliteal collateral index. What is that? This one, you measure the pressure in the upper, above knee and below the knee, and you see what's the difference, you know? And you divide it by the pressure on the above knee. So let's say the pressure above knee like 120 and below the knee like 110. So different only 10 divided by 120, correct?
Yes.
So lower, that mean, what mean different? That mean when it's different between above knee and below knee, not big, that means you have good collaterals, you know? So the reason why you don't need to fix outflow, because there's no difference between above knee and below the knee. So the lower, so when the difference is low and you divide by the above knee, the lower the number, that means you have a good collaterals. The higher the numbers, because a big difference between the artery, that means you don't have enough collateral, then you have to do your outflow. Then fixing the inflow alone is not enough, okay?
Mm-hmm.
This is what we call profundopopliteal. So it's different between above knee and below the knee pressure divided by the pressure above the knee. So anything less than 25, 0.25, of course, that means you have good collaterals, because no difference between above and below the knee, you have good collaterals. So you don't have to worry about outflow, just fix inflow. If the PPCI, what called the index more than 0.5, like 0.9, you know, that means the difference is big. Then that means you don't have a collateral, then you have to fix also the outflow, you know. This is if we want scientific, but the way I look at that, if it's only rest pain, I think opening, get the blood flow to the profunda. If you get flow, fix your inflow. Profunda is wide open, then I think will get you out of the rest pain. If you have tissue loss, I will go more. Okay.
Okay, clear.
Well, let's go to see what they said here. What are the options?
So a lifestyle modification and medical management with aspirin, statin, and cloticestazole. Yeah, this is, I think mainly this is for claudicant patient. Now the patient is presented with wrist pain. I think I do more on this case.
Correct.
So B, atherectomy of common femoral artery and SFA, still not treating the inflow. So I think I will, of course, yeah.
Okay.
C, femoral endarterectomy and profundoplasty with retrograde stenting of the external iliac artery. This looks good option, صراحة, yeah. Especially for patients with wrist pain. D, femoral endarterectomy and profundoplasty with retrograde stenting of the external iliac artery and fembob below knee bypass.
You don't need that because they give you the index. You see, if they give it index like 0.7,
I think I will treat, yes.
And you do that, yes. This is what for the book, for the exam, okay? So 0.5 is your cutoff. Anything less than, you know, the lower is better. So the higher is you have to do bypass, okay?
Yeah.
And the last one, aorta
bypass with antegrade angioplasty and stenting of the SFA. This is too much, I think, for these cases and not applicable. C is, I think, the most
practical one.
Yeah, practical one.
Yeah. Some people they say, yeah, I think this is the best one. Let's see if they talk about the index here, the numbers. Went too fast. Let me see. Index 0.5, significant. Yeah, 0.25, they consider it. Significant benefit from treatment. Celebrity disease may left alone. Didn't talk much, really. All right, but this in general, I mean. But guys, go read about, because you may get that in the exam, you know. We don't do it, you know, we don't practically, we don't measure the index, but it's usually a common question in the exam, you know. All right, well, let's go to Ahmed.
Okay. 55-year-old man presents with leg pain, coolness, and sensory and motor deficits in the left leg, which have been worsening over the past 5 hours. He has no femoral pulse, And CT angiogram confirms iliofemoral arterial thrombosis. The patient is taken for operating room for thromboembolectomy. A few hours after surgery, complains of excruciating leg pain. Which of the following is true regarding reperfusion? I think compartment.
Bowel syndrome, right?
Yeah.
So they like this compartment. You don't get in the exam. Always ask about compartment because it's an emergency. But here I think they ask you about regarding perfusion. I think they want to do with the pathology. Let's see what the options. Go one by one, see if it's true or not.
Okay. A. Reperfusion can cause compartment syndrome only when direct in-line flow to the foot has been established.
In general, when any question say only, this would be wrong because nothing in medicine like only, So this is in general, So I'm sure this is wrong. Indirect flow, that means only if you fix the inflow, you can get, like, I'll give you an example. If you have an clot in the common femoral artery and iliac, and SFA is occluded, okay? What they're saying is that if you do a thrombectomy for the common femoral and external iliac, but you don't have direct inline flow, like when SFA is open, you don't get compartment. Is this true? No, because the leg getting blood through collateral, so you increase flow through the collaterals, still you can get compartment, So you don't have to have inline flow to get the compartment. Just increasing blood flow to the leg after long ischemia can give you a compartment soon. So reperfusion can occur only after reperfusion of the leg. It doesn't matter inflow or through the collaterals. Okay? So this is why it's wrong. Okay, Ahmed, do you understand it?
Yeah, I got you.
Direct inline flow, that means the SFA has to be open, but material has to be open to get the compartment, but it's not correct. You can have SFA and material occluded, and your flow for a long time has ischemia because he has some collateral, leg is alive, and he got an acute on chronic, so he has external and common iliac occluded for many hours, and then you refuse the legs, but just by taking clot from common and external iliac, you can still get compartment. Okay?
Sure.
All right, let's go to the next one.
Reperfusion can cause compartment typically after 24 hours.
No, because we see them a couple hours. You see them, we take them and you finish for 6 o'clock, 5 o'clock, by 7, 8 o'clock they call you, your nurse call you, So usually it will not 24 hours. Usually if you're past 24 hours already, I see compartment. Most compartment happen right after surgery. Always a couple hours, I'm not saying but not 24 hours. Max, usually 5-6 hours, but not at 24 hours, okay? So the typical thing, you finish the case at 5, 6 o'clock, around midnight, 11 o'clock, they call you, the leg patient, a lot of pain, leg is very perfused. The reason why you always need to see the patient at the same day, don't wait next day, So if you do surgery afternoon, be sure you examine the patient at night before you go home, Be sure it has no perfusion. If the 6-7 hour pass fine, really, I think he'll get a compartment after that. Okay?
All right.
So let's do the next one.
C. Extensive lymphatic vessel interruption during surgical dissection can impair fluid outflow and lead to compartment syndrome. You see,
lymphatic can cause swelling, but you see swelling is a tissue. Compartment is different. Compartment is swelling in the muscles, not in the tissue and subcutaneous tissue. You see people with a lymphedema, if you do a CT scan, you see all that swelling in the subcutaneous tissue and the fat, you don't see swelling in the muscle. So,
outside the compartment.
The lymphatic occlusion, yes, can cause swelling and everything, but all at the level of subcutaneous tissue. So will not cause compartment syndrome, okay? So this is also wrong. Well, let's go to the next one.
But in D, pre-existing deep venous reflux or chronic thrombosis, increased muscle edema and can lead to compartment syndrome.
I mean, this is, yes. I mean, if you have a deep occlusions, it can cause a compartment because you already have a venous occlusion, you perfuse the legs, and have a venous occlusions with,
no venous occurrence.
So it gets swollen the muscle, right? But the problem is that nothing in our question, you see, this one questioning this question, is anything they said about venous?
None.
No abnormal pulses, bilateral, taken to everything, nothing.
They did not
So
mention.
even though it's to be correct, but there's nothing in that question. It's not right, it's our question. Nothing in our question said he has a venous occlusion. So this is wrong. Even this is correct, but it's wrong for this patient, you know. So let's go to the next one.
I didn't see it yet.
Last one.
Okay. Inflammatory mediators generated during ischemia increase capillary permeability and muscle edema, which can lead to compound. True.
Yeah, so this is a mechanism. It's very obvious. So this is what happened. You have inflammatory mediator, like, you know, what they call them, the free radical oxygen. They release and they increase the capillary permeability. So you have a swelling in the muscle and cause a compartment. So this is how the pathology goes. So I think this would be the best option for this, the best answer. All right. Any comment from anybody? All right, I think straightforward question, this one. Well, let's go to the next one. Ahlam?
Yes.
Yes.
Yes. An 85-year-old man underwent successful femoral thrombectomy of cardiac embolus for the treatment of acute right leg ischemia. 3 hours following the completion of the operation, the patient developed pain in the anterior and lateral lower leg. The underlying pathophysiology of the acute extremity compartment syndrome is.
So you see, they like this compartment syndrome. You see, the reason why they give us the same questions, you know,
Yes.
that you have a compartment syndrome, you know. So as we say, what happens in compartment syndrome? You have a swelling in the muscles, right? And the swelling muscles increase the pressures where in the venous. See, very high, because you see, also at the capillary, you know, so the blood has to come through the capillary and go out through the venous, right?
Yes, the arterial will be decreased, the venous will be high.
Right, because the blood comes through the arterial, go through the capillary and go out to the venous. So when you have muscles swelled up, the venous pressure goes high, you know, and the perfusing will be decreased. The reason why you can lose a pulse after a while, because arterial blood flow decrease. Yes. So if you don't fix it, if you come say, yes, you see it in the early stage, you see pulses, you feel pulses, but if you don't fix it, like in a couple hours, you lose the pulses even, because the pressure is too high, will decrease blood flow and cause an occlusion, okay?
Yes.
So what you see is, as you said, you see decreased arterial pressure and increased venous pressure, so opposite to this one. So,
yes.
So let's go one by one. Increased arterial pressure, this is wrong.
No.
Decreased
arterial pressure, yes.
Okay.
Decreased venous, no, increased.
Correct.
Increased oxygenation of the muscle tissue reperfusion, no. It's okay. As you said, Dr. Free radical oxygen and mediators. Increased oxygenation of the nerve tissue with reperfusion, no, the same.
Not decrease. The reason why they get damaged, get a nerve damage, the perfusion, because they decrease the flow because the high pressures, you know. So decrease that. Yeah, it's also straightforward. They say they talk a lot about compartment syndrome. So let's next one. Anybody from the audience like to take any question? You are more than welcome, because we have 20 audience here. Otherwise, Muhammad, we come back to you.
Welcome, sir.
You are stuck today with us.
A 22-year-old man who presents with as a level 1 trauma after a high-speed motorbike vehicle crash. He was unconscious at the scene, and upon admission to the emergency department, was found to have a grade 4 liver laceration and left posterior knee dislocation with pulseless foot. Okay. After operative control of the liver laceration, he underwent an external fixation of his left leg, at which time he regained pedal pulses. He was extubated 8 hours later and complained of pain in the left calf, as well as paresthesias of the foot, with weakness in the ankle and toes, despite palpable dorsalis pedal pulses and posterior tibial artery. The next step in management is.
What does he have?
So he has compartment syndrome because of delayed reperfusion.
Yeah.
After the procedure, so
different way. Yeah, the same thing. You know, there was a keep and they want to emphasize on this compartment. You know, You don't want you to miss it, you know. So what would be next step? Let's see what the options are.
For compartment fasciotomy. Yes.
How we do fasciotomy? You are here. Let's talk about it. How we do for compartment fasciotomy?
So you have two longitudinal incision, one medial, one lateral. From each, we enter two compartments.
Let's go by lateral. Lateral. Which compartment you get through the lateral? Fasciotomy.
You will go to the lateral one and posterior, the superficial posterior.
No. You get lateral and anterior.
Anterior. Sorry. Lateral and anterior. Yeah. Posterior كلهم medial.
Yes. So get the posterior both through the medial, get to the deep and superficial posterior. Okay. The most important, guys, to make a long incision. This small incision cosmetic doesn't work, you know. It's very, very important, guys, remember. So always you have to make a really long incision. It's not time for cosmetic. Don't worry about how it looks. If you don't do really a good, you know, long incision, you don't get a good result, you know. And the result is very bad if you don't do it right, you know. So neurologic consultation is wrong. Let's go to B.
Angiography for the evaluation of potential undiagnosed intimal injury. I don't think intimal injury that significant will be with palpable pulse, so it's wrong. CT angio to evaluate for popliteal calf hematoma, less likely, and emergent operative decompression, and for compartment fasciotomy. I think this is the answer. Below knee amputation.
Hopefully
if you don't do this, you do that.
You can't do that. What about measuring the pressure? You think we need to measure the pressure, or do you do guys measure the pressure? Is there any need for that?
Usually it's clinical data, but it's not like the abdomen you have to, and you're in doubt. But I think it's clinical diagnosis. If you are you have to have high index of suspicion. If it's even negative fasciotomy, better to do it.
Yeah, that's true. I mean, usually we don't measure the pressure. Unless if you're in doubt, very questionable, you know, then you do it. But usually you don't need. The moment you see a tense and the signs, pain, and especially with the dorsiflexion, you see a pain, then this is very classic for compartment. So don't waste your time with that, you know. But if you decide to do it, it's very simple. Just get a needle. I mean, they have a special needle, but you don't have to spend all this money. Just get any needle and hook it to the central line, you know, measurement the same they use for central line, and put it in the compartment. Usually measure more than 30 to 40 from the mean pressure they consider diagnostic. But if you have a doubt and pressure is low, go with a fasciotomy, as Muhammad said. Better to be on the safe side than you miss compartment, you know. This is only like if you're not very 100% sure, like you're 50-50, then you measure the pressure. But if you think the pressure is high by physical exam and he has the symptoms, and you measure the pressure, even if the pressure is low, I will do that, because must be something wrong with your measurement. I will do fasciotomy, okay? But if they ask you about the pressure in the exam, usually 30 to 40, okay?
Yeah.
Of the mean pressure.
Yeah.
All right, let's go to next one. Maybe you should take next one, Hamad. This isn't easy for you. I mean, the one we passed. So let's see, what is that? For compartment fasciotomy. Let's see, 20. Oh, so we are 30 now?
No, we jumped.
We jumped to, let me see.
We jumped to, I was 29.
Oh, the compartment, it looks called compartment. Let me see.
Yeah.
Oh, you're right, another compartment. So should be 30 now? We finished at 29.
30. I took 29.
Okay, let's go to 30. Take it. It looks like also compartment. Let's go.
Compartment.
It's a compartment day. Let's see what is that. Go ahead, take it. You see, long history, and then answer is 2 minutes, you know?
Yeah.
What is that?
A 54-year-old woman presents with worsening anterior calf pain. 2 hours earlier, she had undergone an emergent thrombectomy for acute limb ischemia due to thromboembolic occlusion. She had complete restoration of pulse and was motor intact immediately post-operatively. After that, she had tenderness in the anterior calf on the operated side. So with limited ankle motion due to pain, the distal pulse examination is unchanged. She had paresthesia of her toe and numb in the first interdigital web space. The most appropriate action is, so this is again delayed drip refusion with compartment syndrome. So
okay, this is good.
So yeah.
Why they give you what time? Oh, we still have 5 minutes. Why they give you this first interdigital web space? Why they give you this one? Numbness in the only first interdigital web space.
I don't know, صراحة.
Because this is only one is derived by the deep peroneal nerve.
Yeah,
deep nerve was sensation only to this small web space between first interdigital web space. So just to know, because they may ask a question and they put this sentence, you know, the moment you see sentence, this one, they talk about deep peroneal nerve, which usually is the most common nerve damage in the compartment, right? When you have compartment, the most nerve damage, because the most common department where, which compartment usually get the most tense?
The posterior.
Lateral or posterior?
Posterior.
لا محمد anterior. لانه الانتيريور is small, see posterior is big وهذا قليل يعني هذا. So most compartment happens anterior compartment, and the most common nerve hit there هو anterior lateral هو البيرونيال nerve. بالposterior compartment usually posterior nerve, posterior tibial nerve damage, which rarely we see it. The reason why the first sign of compartment is the foot drop, which is damage to the peroneal nerve, which usually comes from the anterior compartment. So, and it supply all the sensation to this first interdigital web space. The reason why. So if you see it in the exam, remember that is they put a different scenario, mention this one, they're talking about deep peroneal nerve, okay?
Great.
All right, so let's see what option. I think it's just fasciotomy. I think all the options could be, you know, so fourth compared to fasciotomy. So let's not waste our time here. Okay, Ahmed, let's go to 31. Maybe have a couple of questions before, maybe a couple of minutes. Maybe we can do 2 more questions. Okay, Ahmed. Hopefully it's not important.
Okay.
55 years old. Go ahead. You see it?
I don't see it yet.
Oh, it's a delay between me and you.
A 55-year-old man who suffered a complex fracture femur is transferred 4 hours after the accident. He went to the operating room with an orthopedic surgeon. A few hours later, intraoperatively, initially he had no distal pulses on the affected limb, but had palpable pulses at the end of orthopedic procedure. Overnight, he noted new worsening pain in the affected limb. On examination, the lower leg was noted to be swollen, warm, with palpable pulses, but significant pain to passive dorsiflexion of the great toe. If not treated expeditiously, the nerve that is most commonly to suffer permanent is common peroneal. Anterior. Yeah, common peroneal.
The peroneal nerve. But we have 2, superficial and deep. Let's see what the option they give you. Superficial, deep, femoral profunda, and medial posterior tibial nerve. Wow. Okay. We need somebody who recently read anatomy, who can remember all those nerves, what this applies. It's tough one. Muhammad, you just took an exam, second year. Anyway, superficial peroneal nerve and deep peroneal nerve. I mean, we just talked about the great toe. Superficial peroneal nerve mainly is sensory. It has, I think, only a couple muscles he supplies, not important muscle. I don't think it comes to the toe. But deep peroneal nerve is the main muscle supply for the anterior compartment and the big toe. So the big toe is from anterior, compartment. So really the main supply muscle motor for the anterior compartment is the deep peroneal nerve. Superficial peroneal nerve mainly sensory and have only a couple muscles, which is not, I think, important. So when you say the great toe dorsiflexion or ankle dorsiflexion, most is the deep peroneal nerve. Okay.
Yes.
Femoral nerve is more sensory and more the muscle of the thigh. So most of it affects the knee. Flexion, extensions. Profunda femoral nerve. I don't know what this applies. Medial posterior tibial nerve. This is from posterior compartment. I think this is also posterior muscles. Mostly affect the flexion, not dorsiflexion, the flexion, the flexion, not the extension, the peroneal is the extension. Anyway, but in general, guys, when you see compartment, always think about peroneal. This is simple, but now it make it be difficult because superficial and deep. So, but again, with a great toe, it is peroneal. Or they gave you this, what I said before, the small space sensory. This is a deep peroneal nerve, okay? All right, let's finish it with Ahlam. Keep the best to the end. Here we are.
Thank you.
Ahlam, here we are, 32.
Okay.
Let's pick up with compartment.
A 55-year-old woman with insulin-dependent diabetes present with non-healing diabetic ulcer and neuropathy after she walked on her child's toys a few days earlier. Her lab values are abnormal with fasting hemoglobin A1C 12. She has no palpable pulses with toe brachial index 0.2. The component that define pathophysiological triad of diabetic foot ulceration are.
Well, let's go and start before with that. So she has a vascular disease, right? She has ulceration.
Yes.
She has neuropathic also.
Yes.
A is 12. Guy, what normal what ACA should be?
Less than 6.
Yeah.
7 or 6.5, some 6.
Yeah, around 5, 6. So should be below 5, 6. So 12 is already high. So that means has no controlled diabetes. Index 0.2 is very bad. So she has a vascular disease. She has a neuropathy. So usually in diabetic people, what they want, what's the 3 things cause diabetic ulcers? We mentioned 2 here. The neuropathy and
ischemia, infection, and neuropathy.
Yeah, so the third one we are missing is the infection. This is the 3 things cause diabetic ulcers, the 3 one. So I think that's what the question about. So let's see what options they give us here.
A, neuropathy, arterial occlusive disease, and trauma with secondary infection, correct?
Yeah.
Hyperglycemia, hyperlipidemia, and repetitive trauma.
Yes,
no, this is not the triad.
Not a triad, but this is correct. I mean, hyperglycemia, hyperlipidemia, but it can cause that, but it's not that triad for diabetic foot. Yes.
Yes. Neuropathy, muscle atrophy, and bone deformity all happen because of the pressure zone is changed due to neuropathy and also muscle atrophy.
Okay.
But it's not the triad.
Correct.
Hyperglycemia, arterial occlusive disease, and skin barrier deterioration. Also correct, but not the triad.
And the last one, the same thing.
Neuropathy, glucose, and muscle, the same.
I think that was the trial. We know it's vascular, neuropathy, and infection. These are the 3 things. Yeah. I think it's straightforward. What time? It's been an hour, guys. Any question before we go? Anybody want to make any comment? Anybody want to add anything? Any questions? Any concern about any subject we talk about today? All right, guys. Everything looks fine. Ali, you still here, Ali?
Yeah, I'm here.
You want to add anything, Ali?
No.
I think it's straightforward. I mean, the question is not like very complicated, As I said, lower extremity, it's not a difficult question because the bread and butter we do every day, So should be an easier than carotid and aortic, All right, guys. So we'll meet next week, hopefully, and have a great night. Take care.
Thank you, Samer.
Thank you, Dr. Samer.
Thank you. Thank you.
Thank you.